Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Menopause marks the end of a woman's reproductive years. It's a natural part of aging that many women have questions about. So today, I'm talking with Dr. Maureen Burke. She's Chief of General Obstetrics and Gynecology at Upstate. Welcome back to the Informed Patient, Dr. Burke.
Thank you, Amber.
If I understand correctly, menopause is when the ovaries stop producing reproductive hormones. Is that right?
Yes, that's correct.
So what age does this happen?
There's quite a wide age range for natural menopause. It can start as early as age 40, or some women don't go through menopause until their late 50s.
So what is perimenopause?
Perimenopause is a number of years before somebody actually gets to menopause, where their hormones start fluctuating much more significantly and they start seeing some changes in their menstrual cycles. So typically women have one period every single month in a fairly predictable time frame. But during the perimenopause years, as hormones start to fluctuate a little bit more, women start to see that their cycles space a little bit more. They might go more than 7 days of variation. So, if an average cycle is 28 days, maybe they're getting a period after only 21 days, or going out to 35, 36 days before they get another period. And then as they get closer to menopause, the time between their menstrual cycles can increase even more, up to 60 days or more in between periods.
So how early might a woman see that start? Would that ever be in the late 30s?
It could potentially be in the late 30s, yeah, for people who go into menopause in their early 40s.
Now, can you get pregnant during perimenopause when you're still menstruating,
Question.
but
Yeah.
it's erratic?
Yes, I should clarify when you asked me, is menopause when the ovaries stop producing hormones? And the answer is yes. But the clinical definition of menopause is actually going 12 months in a row without a period. So perimenopause is when we start to see those menstrual irregularities, and then we hit menopause when we've been 12 months in a row without a period. So during perimenopause with those menstrual irregularities, yes, you can still get pregnant. It's actually very important for anybody who is sexually active with a partner who can produce sperm to continue to use contraception during that time frame unless they want to be pregnant, because it's harder to predict when ovulation is happening. When the menstrual cycles are shorter or longer, you don't know exactly when ovulation is happening. And that's how people sometimes end up with a surprise late 40s baby.
Now, you said it's 12 months without a period. Are there other symptoms besides that to be aware of?
Yeah. So for people in perimenopause, into menopause, and after they've gone through menopause, there are a lot of symptoms that are related to the changes in estrogen levels. So the estrogen level is what really drops at the time of menopause, and that can cause a lot of symptoms, including hot flashes. Probably about 80% of women worldwide experience hot flashes during menopause. It can also cause mood swings for people who've never had mood disorders before, or it can cause worsening of mood disorders that people already have, especially anxiety or depression. And it can cause vaginal dryness, which can have a lot of, negative impact on daily health as well as sexual functioning.
Do you ever test the hormones of a woman to find out for sure if she's in menopause?
That's a great question, Amber. And unfortunately, measuring the hormone levels doesn't give us as much clear information as we would hope. For women who still have a uterus and had been getting periods, that definition of 12 months in a row with no period is really the best definition of menopause. Situations where we might measure a hormone level are ones where women haven't been getting periods regularly, usually because they've had their uterus surgically removed in the past. As they start to get symptoms of menopause, hot flashes, vaginal dryness, mood swings, sometimes we will check a hormone level, and the hormone level we check is one that goes up as we're heading towards and into menopause, but it starts to elevate before that clinical definition of 12 months in a row with no bleeding. So it's kind of an inexact measure of menopause.
But like you mentioned, some women may have surgery or medical treatment that puts them into menopause early. Will their symptoms or their experience differ from someone who enters menopause naturally?
People who are forced into menopause through use of medications like chemotherapy or because they've had their ovaries removed with a surgery often have a much more dramatic experience of menopause because instead of living through a number of years where their hormone levels are fluctuating back and forth, they just hit a wall where the hormone levels drop really significantly all at once. And so a lot of times they'll notice those symptoms, especially the hot flashes and maybe the mood swings as well, coming on pretty intensely all at once.
Some of the side effects of perimenopause, which you've mentioned some of them, they can have a huge impact on quality of life. So I wanted to ask you how you recommend patients treat hot flashes, for instance.
Flashes definitely can start before menopause, so during the perimenopausal period. And really, the best treatment for hot flashes is management of hormone levels through use of estrogen. We always talk about lifestyle changes, wearing layers, having a fan nearby, being prepared to take off layers and put on layers. But that's really management of symptoms. It's not treating the symptoms or preventing them. And estrogen use is really the best way to manage those symptoms, sort of for the long term.
Now, does estrogen help with the mood swings and irritability?
Yes, it can.
What about insomnia?
The relationship between using estrogen and whether or not it helps sleep is a little bit less clear. But if there's no reason not to try estrogen for insomnia. And if people are able to sleep better, then often their mood swings get better. So there's, kind of a direct relationship there. Or people who have mood issues sometimes struggle with sleep. And if their mood is better, sometimes they can sleep better. There's definitely non-hormonal options for management of insomnia. There are some over-the-counter medications like melatonin that can be helpful. We don't really recommend long-term use of prescription medications to help people fall asleep. And actually, the best strategy for management of insomnia is a type of cognitive behavioral therapy that's targeted specifically towards insomnia.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith, and my guest is Dr. Maureen Burke. We're talking about menopause. Let's talk about any lifestyle changes or activities. Are there things that a woman can do on her own that might help this transitional period?
How much people feel their lives are impacted by menopause symptoms can vary a lot. And people who have a more active lifestyle, in terms of physical activity, as well as healthy eating habits and a strong social support network, tend to manage their menopause symptoms or tolerate their menopause symptoms a lot better. So studies actually show that women who have few social connections or are having other life stressors at the same time that they're going through menopause tend to have a worse experience of their menopause symptoms than people who are well supported socially, or are in a sort of well-balanced place in their life.
What about any vitamins or herbs? It used to be soy was a big thing people tried. Are there any supplements or foods that you recommend?
Not that specifically treat the symptoms of menopause. So, soy, when it's broken down in the body, some of the byproducts of soy turn into hormones that are similar to estrogen or become estrogen-like in the body. But there's not really any strong evidence that eating some certain amount of soy provides adequate estrogen supplementation to support those symptoms. So, really, what we recommend in menopause is a healthy diet, Mediterranean style diet, or a diet that's high in fiber, high in fresh fruits and vegetables, low in the bad types of fats, is the best kind of diet to protect long-term health. So one of the things that we haven't talked about yet is that when our estrogen levels drop, there is an increase in the risk of heart disease. So estrogen actually supports our heart. And when we lose our estrogen at menopause, the rate of heart disease goes up. And so it's extra important as we hit menopause and go beyond menopause to make sure that we're eating a heart healthy diet and maintaining good physical activity levels.
Now, science has gone back and forth on this hormone replacement therapy. So I'm wondering what the consensus is today in terms of replacing the estrogen that the ovaries are no longer making. Is that a good thing to do?
Yes, the consensus today is that for almost everybody, using estrogen to replace what is being lost by the ovaries is safe and effective. One of the reasons that medical professionals really started shying away from using estrogen in the early 2000s was because of a study called the Women's Health Initiative, which was a large national study looking at whether estrogen could be used to prevent heart disease. So the women that were being studied were women who were starting to take estrogen mostly in their 60s and 70s, who were well past the age at which they'd gone through menopause. Most of them were more than 10 years out from menopause. And in that longitudinal study of women who started taking estrogen later in life, it actually showed that there were some significant health risks to starting estrogen that late in life. But when they re-looked at the data, including women who were much closer to menopause when they started the hormones, they didn't find those same health risks. And since the early 2000s, there have been a number of very well-designed studies that show that starting estrogen at the time of perimenopause or menopause, or within 5 to 10 years of going through menopause, the benefits are very high and there's really very little risk to most people. There are some chronic medical conditions that make estrogen use unsafe. So it's always important to talk to your doctor about the specifics. But for most people, estrogen supplementation at the time of menopause is very safe. We don't say that estrogen should be used for primary prevention of heart disease. So we know that women who take estrogen through the perimenopausal and menopausal transition do lower their risk of heart disease, but we don't prescribe estrogen exclusively for that reason. We prescribe it for other reasons, and then this is a kind of an added benefit.
Does that guard against problems with the electrical activity of the heart or structural plumbing problems with the heart, or both?
It guards against more of the plumbing problems. So reduces the chance of heart attack, which usually has to do with the blood vessels getting clogged or thinned.
Does taking hormone replacement therapy prolong perimenopause?
Really, I think the answer is no. So we're not postponing menopause itself. So starting hormones in the perimenopausal period doesn't change when somebody goes 12 months in a row without spontaneous bleeding. It just alleviates the symptoms that they're experiencing. And some people only experience menopausal symptoms for a few years after menopause, but some people experience those symptoms lifelong, which is why we say that it's okay for people to stay on estrogen long term, because they can basically use estrogen to prevent or manage those symptoms indefinitely as long as they don't develop any medical conditions that make it unsafe. Some people are able to take estrogen for a few years and then kind of taper the dose slowly and kind of let their bodies adjust in a slow transition to a lower dose of estrogen. But for most people, there's no harm in staying on estrogen for the long term. As we get older, our likelihood of having chronic medical conditions like high blood pressure or developing a blood clot or developing certain types of cancer goes up. And some of those medical conditions, once a person develops them, really it's no longer safe to be on estrogen. So it's important to continue to have conversations with your doctor about whether there's anything changing in your health that would make estrogen unsafe. But for most people who start estrogen, it's okay to take it lifelong if they want to.
We talked about perimenopause before menopause. What is postmenopause? When does that start?
Postmenopause is basically the entire time that you're alive once you've gone 12 months in a row without a period.
So
So
you're postmenopausal the rest of your life.
yeah, and with the life expectancy that we have today, that can be up to 40% of a woman's lifetime.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Maureen Burke about menopause. What are bioidentical hormones?
Bioidentical hormones are hormones that have a chemical structure that is the same as the chemical structure of the hormones produced by our body. So any hormone that we take in has been produced in a lab, whether it came from a plant or whether it came from some chemicals that were just put together from small chemicals into a bigger chemical that we call a medication. But anything we're putting into our body that's hormonal came from a lab in some form. And so some of the forms of hormones that we get are bioidentical, meaning that they have the exact same chemical composition as what we produce naturally. And some of them have a slightly different chemical composition.
How does menopause affect a woman's sex drive?
It's pretty common for women to report that their sex drive goes down around the time of menopause. Some of that is probably not directly related to menopause. There's a lot of life changes that happen for people in their 50s. It can be a very stressful time of life in terms of what might be happening and taking care of our parents, taking care of our children, relationship issues with spouses, stressors at work. And anything that causes stress can also impact somebody's interest in sex or responsiveness to romantic encounters. But the loss of estrogen does also sort of drop people's libido, and a lot of women feel that it's harder to feel interested in sex. Although most of the time, if they are in a relationship with somebody and they sort of are able to get into a romantic encounter, their ability to respond is still there. So sometimes it's the initial interest that's gone, but responsiveness is still there.
Now, after 12 months of no menstrual periods, if a woman notices vaginal bleeding, is this ever normal or what does she need to do?
If it's been more than 12 months since the last period, it's very important for a woman to talk to her doctor about any vaginal bleeding that she experiences. There are a number of reasons people can have vaginal bleeding after menopause. The most concerning reason is uterine cancer. It's definitely not the most common reason. The most common reason is actually that the lining of the uterus or even the lining of the vaginal canal has just gotten very, very thin. And sometimes it bleeds from being too thin. But it's very important to check for cancer because that's something that we want to catch as soon as possible to be able to have the best opportunities for treatment. So any vaginal bleeding, a woman should report to her doctor.
Now, once she's postmenopausal, does a woman still need to see a gynecologist every year?
Typically, we recommend that they do. There are a lot of things that a gynecologist checks in about that don't have to do with periods. We still want to make sure sexual function is okay, and we have ways to support people who are having difficulty with sexual function. We check for symptoms that could be warning signs of breast cancer, uterine cancer, and ovarian cancer in those visits. Most women are still getting pap smears at least into their 60s to screen for cervical cancer. And sometimes the gynecologist is also sort of a primary care provider, checking high blood pressure, screening for diabetes and thyroid disorders and things like that as well.
Are postmenopausal women at greater risk for breast cancer?
They are, but it's not so much because they've lost their hormones. It's just a factor of aging.
I see. Now, what about osteoporosis? Is there anything that's done during postmenopause to guard against that? And that's the thinning of the bones.
Yes. Osteoporosis is very low bone density, and anyone with osteoporosis has a higher risk of getting a bone fracture. We start to think about risk of osteoporosis when people are around the age of menopause. Most people in their 50s are not at risk of osteoporosis, but certain chronic health conditions, as well as people who are very thin, or have digestive issues causing malabsorption can be at higher risk. So we start to think about what those risk factors are, and we may do screening tests that are a type of X-ray called a DEXA scan to assess bone density. Now, women who don't have particular risk factors really don't need that screening test until they're about 65 years old. But for people who are at risk of low bone density around the age of menopause, if we find that their bones are already kind of on the lower level of density, estrogen can actually be a primary treatment for or primary prevention for osteoporosis.
We talked already about estrogen's protective effects for the heart. Is it typical for a gynecologist to tell a woman in her 60s to see a cardiologist?
We don't recommend that everybody see a cardiologist. We really base that on personal history, other chronic medical conditions, and family history.
Well, let me ask you in general, what do you tell your patients who are entering perimenopause? And I imagine, there's some anxiety about these symptoms that are coming on and the change about this time in their lives. Do you have some general advice for them?
Certainly, I think it's helpful to have a conversation. Some people come into my office reporting a change in their menstrual cycle, or, they're not sure if they're having hot flashes or mood swings and they have questions about it. And I think talking about it earlier rather than later as we get older is important to help people feel comfortable and understand that what is happening to their bodies, although it may not be enjoyable, is a natural process. I think a lot of people get worried when they see something about their body changing. And so being able to talk with patients about what's normal and what's not normal is really helpful.
With a lot of women postponing childbearing until later years, what is that doing to perimenopause? Is it pushing it back, or is perimenopause not going to change?
There's really no evidence that when women have babies impacts when they go through menopause. One of the factors that causes us to stop producing estrogen from the ovaries is loss of eggs. But when a person is pregnant, doesn't really impact the rate at which we're losing eggs. We're born with all the eggs we're ever going to have. And even before we start getting periods, we've lost a significant number of eggs. Eggs are being lost every single month. And that loss increases in terms of how many eggs are getting lost as we get older into our 30s and 40s. So it is one of the reasons actually that women in their late 30s and early to mid 40s have a harder time getting pregnant. They have fewer eggs overall. But whether their first child is at 18 or 38 or 45 doesn't really seem to have any impact on when they go through menopause.
This has been very interesting, and I appreciate you making time for this interview, Dr. Burke.
Sure, it's been fun to talk to you, Amber.
My guest has been Upstate's Chief of General Obstetrics and Gynecology, Dr. Maureen Burke. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.